Thank you, ma'am, for the introduction and good afternoon. So, given topic today to me is anticoagulation and venous access for the pediatric apheresis. I planned my topic in just brief about a few slides of apheresis, particular the classification, particular anticoagulation and its complications, venous access and its complication, and the conclusion. So, as we all know, apheresis means we are just separating. On the basis of separation, what we are collecting, a red cell, a platelet, or plasma, we are naming them, and that rest of the component will return back to the donor. Besides the normal collection, we can apheresis can be utilized as a therapeutic purpose for the various clinical conditions. So we named those conditions in therapeutic apheresis, where we are removing or manipulating the infected cells or the immunoglobulins or antibodies or protein-bound toxins. The efficacy can be increased by concomitant drug therapy or particularly by immunosuppressive therapy in immune mediated disorders. So it can be utilized as a rapid acting and short term adjunct therapy uh, to the chemotherapy or the immunotherapy. We can classify them as a therapeutic and non-therapeutic. So in non-therapeutic, we are just collecting the respected components, and in therapeutics, we are treating the patient directly. So currently, the machines are available based on centrifugation technique, and the kits or the disposable set are unique to that particular instrument or the machine only. It can be intermittent flow type also, and it can be continuous flow type. Mostly instruments are continuous flow type instrument. They can be single access needles or single vein access or dual vein access. The duration of the procedure are varies, depends upon what we want to collect and what procedure we want to do. So these are the various instrument from the various companies, like from Haemonetics MCS Plus, from Fresenius Kabi, Comtech, Amicus, from Teramo Penpal, Spectra Optia, and Trima. They're based on single double needle access, and we can do any kind of a procedure on these instrument. So starting with the anticoagulant first, the anticoagulant is essential for every apheresis procedure, whether it is therapeutic, whether it is non-therapeutic, because anticoagulation can prevent the clotting, which is activated by the foreign surfaces of the tubing. So it lead to contact mediate activation of the platelets. So it prevent by the anticoagulation. We can use two types of anticoagulant, the citrate type and the heparin type. The citrate is the choice for any kind of blood additives and extracorporeal circuit, where we are using low blood flow of the blood flow rates. In apheresis, the citrate also the choice of anticoagulant over the heparin because of its low cost, safety, and the rapid clearance from the body. It exerts the anticoagulation effect by the chelation of divalent cations like calcium and magnesium. The most commonly used formulation is acid citrate and dextrose. It can be ACDA or ACDB. Depending upon the concentration of the citrate, they are varies in ACDA, ACDB, and sodium citrate. Sodium citrate contains maximum citrate percentage, so they are rarely used in any kind of apheresis procedure. Most commonly used are ACDA. And when these anticoagulant are used with any additional citrate content blood component like FFP or PRBC, the citrate level can be increased because of the combination. That there are two main part or context in the every apheresis procedure. First is the rate of the anticoagulant delivery to the patient, and the second one is the anticoagulant delivery to the extracorporeal circuit. Okay, so for extracorporeal circuit, it maintaining the effective anticoagulation, so there will be no clotting, and the dose, basically citrate dosing is, we know it's a higher rate of the infusion than its a removal, because we know the physiology that the donor can tolerate up to 20% of the dip of the ionized calcium, so it will permit a higher infusion with a shorter period of time of the procedure. We can cut down the time. Every instrument, whether it is intermittent or the continuous flow type, it's calculate the total body volume, and based on that, they calculate the rate of delivery of the anticoagulant. Whether the calcium level, mostly instrument are calculating or controlling the AC infusion to 1 to 1.8 milligram kilogram per minute. In various studies, the 0.8% of ACD to total body volume is associated with the 10 to 15% of the calcium, ionized calcium. One is associated with up to 25%, and the 1.2 is a maximum ACD infusion will lead to up to 35% dip of the ionized calcium. Once the parameter of ACD infusion rate is fixed, operator can configure the a next procedural parameter of to the circuit only. Once we finish with the patient, we can set to the we can go for the extracorporeal circuit. In the extracorporeal circuit or in the machine itself, there are three main the points which have to be considered. First is the inlet pump rate, which delivered the anticoagulated blood to the centrifuge. The second is the AC flow rate, which delivered the ACD to the patient blood, and the finally is the whole blood to AC ratio. It is the AC ratio. Most of the instrument is we are fixing the AC ratio is 12:1, means we are taking 12 parts of the whole blood and 1 part of the anticoagulant. So the higher the AC ratio, there are chances of clotting or the clumping is there, and less is the AC ratio, the more delivery of the ACD is there, so more cytotoxicity will be there. So these three inlet AC flow is proportional to the delivery of the ACD, and the whole blood to AC ratio is inversely proportional to delivery of the citrate. So as I said earlier, most of the instrument are fixing their AC ratio to 12:1. Citrate toxicity is the most common complication of anticoagulation, and the cation chelation is there, but that blood goes into the patient, that citrated blood goes into the circulation, and it will lead to metabolic complication, like Dr. Anupa said earlier. The variety of procedures by the FRSs tend to generate a mild type of most common citrate type of reaction is perioral tingling and paresthesia. And the frequency of the citrate toxicity more in the large volume processing FRSs procedures, like in PVSC, like in TPE. The citrate-induced hypocalcemia is again the most common because of the citrate toxicity, and that can be rate of infusion, citrate infusion, the rate of the decline in ionized calcium level in the blood, and hepatic metabolism of the infused citrate. So these are the severity of the hypocalcemia from perioral to severe cardiac arrhythmia and seizure. But the perioral and paresthesia, acral paresthesia is most common. We can overcome the citrate toxicity and the hypocalcemia by the giving patient or donor to the oral calcium supplement, or by the slow infusion of the calcium. Like we in our setting, for every stem cell donor or the patient, we tend to use a slow infusion over the period of whole the 4-5 hours or 10 ml of the calcium gluconate in the 100 ml of that saline. Yeah, coming to heparin type of anticoagulation, mostly unfractioned heparin are in use, but they are limited to certain indication, like you can combine with the citrate, large volume leukapheresis, and alone, if we are using, then we can use in membrane-based plasma exchange where the flow is high, okay, and LDL apheresis and photopheresis. When we are using heparin along with the citrate, the whole blood to AC ratio, we tend to set as low as 1:25 to 1:30. And then after that, heparin bolus and followed by continuous infusion of the heparin. And we have to monitor the activated clotting time to 180 to 210 seconds. All heparin exert their primary anticoagulant effect by binding the antithrombin and finally lead to rapid inactivation of thrombin and factor 10A. So it's finally lead to bleeding or the hemorrhage. So major complication by the heparin anticoagulation is the bleeding, and it can be correlated with the other coexisting procedure or disease or concomitant antiplatelet therapy or intensity of the coagulation. Coming to vascular access, all apheresis, whether it is non-therapeutic, is the therapeutic. The vascular access should be there because there are two types of procedure where one kind of procedure we need a slow flow rate, like in centrifugation, and another kind, membrane flow, we use a high flow rate. There are two types of vascular access. First is peripheral blood, peripheral venous access, where we generally use antecubital vein for the access, and we use 16 to 18 gauge, preferably 16. If not competent, then we can go for 18. And we tend to draw the blood by 80 ml per minute. And central venous catheter, there are two vein for CVCs, like interjugular vein and femoral, mostly for the children. Peripheral venous access is a preferred choice, where we use 16 or 17 for the inlet or for the withdrawal and the 18 for the return line. Where the peripheral access is not available, we can go for CVCs like central venous access, where we can use, we can do multiple frequent procedure. We can where the patient is unable to provide the hand compression to maintain a vascular flow. Wherever we use central venous access, the wall should be rigid, as Dr. Anupal said in earlier lecture, that they tend to generate a negative pressure in the line. So we use a rigid line or rigid walls, tunneled, cuffed catheter. So dual lumen catheter is when those used in hemodialysis are choice of the catheter. For short term, yes, we can go for the non-tunneled one, but when there are long-term procedures or the long duration procedure, the tunneled and cuffed central venous is good for the stable and the safe procedure for longer duration. Compared to non-tunneled, tunneled CVC central have a lower chances of infections. Another type of central venous catheterization is PICC line that typically do not support the adult apheresis procedure, but we can go for the pediatric with the PICC line because there is a slow flow rate in the pediatric population, but it needs care. PICC line needs care. And another type of implanted subcutaneous ports for the CVCs are totally implant level venous access devices. Those can also provide a long-term access to the procedures. The choice for the placement site depends upon the duration of the procedure, how long it's going to be happen. Subclavian and internal are good for the TP kind of a long duration procedure for the, or we can go up to several weeks, but femoral vein for the temporary because there are chances of infection. Good catheter care should be there. So either by the transfusion medicine specialist or the clinician side, they both have to take care of the venous access. It should be flushed regularly by heparin or 4% trisodium citrate. If it is clot, then can use fibrinolytic agent for the patency. The complication, peripheral blood has, peripheral venous access has less chances of infections and can done immediately. There are chances of infection, very less venous infiltration, patient discomfort because you have to put the arm for long duration. Central venous have more complication than the peripheral venous access, can lead to infection, thrombosis, hemorrhage, venous stenosis, and catheter associated sepsis. To conclude, it is almost safe procedure. There are no serious complication either related to any kind of but for pediatric, few things have to be considered in mind very specifically, like technical procedural, vascular access, anticoagulation, and psychosocial aspects. These machines and the principle are mainly for the adult population, but the infant or the young children should need extra attention. Every instrument has the physical characteristic of the FRS instrument, like extracorporeal volume, patient clinical condition, and total body volume should be calculated. The extracorporeal volume varies from equipment to equipment and within the equipment from procedure to procedure. Citrate is the preferred anticoagulant. There can be a citrate toxicity, but it can be managed by oral calcium supplementation or continuous infusion. And heparin can be used along with the citrate anticoagulation. For children, central venous access is good. One for the dual kind of central venous access is good. One for the inlet and another for the return. And patient cooperation is very essential because there can be a discomfort for the pediatric population. So distraction technique like electronic media, parent or family support to make the child comfortable throughout the procedure. Thank you.
Thank you, sir, for your excellent presentation on this critical aspect of pediatric apheresis. Your insights have truly enhanced our understanding of management of patients with small blood volumes.